Hello and welcome back. So today I'll be discussing the cardiac examination part B, which will be the cardiac sounds S1 to S4. So this will be our fifth video in the approach to chronic dyspnea. So this will be the general layout of the discussion. We'll first discuss the our alterations in the loudness of the S1 sound, then the splitting of the S2 sound, the S3 sounds, and the S4 sounds. Okay. So this is a diagram that we've seen in the previous discussion. So as I have already discussed previously, this is the pressure volume curve, pressure versus volume for the left ventricle. Now so as I have alluded to in the previous discussion, the opening of the AV valve corresponds to the initiation of diastole. Okay, so this is where the AV valve opens. So in this case, it is a mitral valve, and the end of diastole corresponds to the closure of the AV valve. So this is where the AV valve closes. Okay, and obviously this is the point where the aortic valve opens, and this is where the aortic valve closes. Okay, now it is the closure of the AV valve which produces the S1 sound, and it is the closure of the aortic valve and the pulmonic valves, the pulmonary valves together, that produces the S2 sound. Okay, but the major component in a normal person is typically the S2, is the A2 component, so that is the aortic valve. So moving on, so what causes alterations in loudness of S1? So the first thing is, what are the alterations in loudness of S1? So obviously one is that it can become louder, the other thing is that it can become softer or less loud. So when do we say that it is loud? So S1 is said to be loud when, so see, at the apex normally S1 is louder or more intense than S2. That is because S1 is caused by atrioventricular valve, that is mitral valve closure, and that directly conducts to the apex, and that is where it is heard best. However, at the base of the heart, that is in the pulmonary area and the aortic areas, the S2 sound is normally louder than the S1 sound. So if at the base of the heart what happens is that the S1 sound becomes louder than the S2 sound, then we say that S1 is loud. Okay, the softness of a soft S1 is more of a subjective finding. So that is something that we describe subjectively, but loudness is defined as I have just previously described. So let's talk about what are the factors that affect the loudness of S1. Okay, so the factors are as follows. Basically what happens is, you got your left ventricle during diastole. Now as the ventricle dilates, as we've discussed, the initial part of diastole, the ventricle is dilating, it is expanding. Okay, and it is this expansion that produces a negative pressure inside the left ventricle, and that pulls blood from the left atrium into the left ventricle. Okay, and this corresponds to what we call the early rapid filling, and non-JVP, this corresponds to the V wave. Now this pushes the blood that is coming in, pushes the mitral valves away from their closed position. Okay, so this is the closed position of the mitral valve. Okay, so it pushes it away. Now as blood moves into the left ventricle pressure starts to rise, so it goes from being negative to becoming more and more positive, as we've seen in the previous talk. So that then in the second phase causes it causes the leaflets to move back. So they've come till here, so the leaflets slowly move back towards their closed position. But obviously at the end of diastole we have atrial contraction. So since the atrium is contracting, there is positive pressure now in the atria, and that pushes a little bit more blood, 20 to 30% of the total blood that goes in diastole from the left atrium to the left ventricle into the left ventricle. Okay, and that then again pushes the leaflets away from our neutral position. Okay, so this is what is happening during diastole, and in this diagram that we've discussed previously, the pressure volume curve, these three diagrams at the bottom, they represent our diastole. Okay, so in this first diagram, what is happening is there's negative pressure inside the left ventricle, and that is pulling the leaflets towards the apex. Okay, and actually on when we do a echocardiogram, which will be our subsequent talk, this movement of the leaflet forms on M mode echocardiography what we call the E wave. Okay, now so it actually corresponds to early rapid filling, so E. Okay, then what happens is as the ventricle gets filled with blood, the negative pressure within the ventricle becomes less and less. So this yellow that what we as previously described in the previous video, it is represents a reduction in pressure or a more negative pressure. So the intensity of the yellow is becoming less, so the pressure is becoming less negative. Okay, so that is why diastasis occurs, and that is when the leaflets are going back towards their closed position. Okay, now lastly there is atrial contraction, and that produces a positive pressure within the left atrium that pushes more the leaflets again towards the apex. So fine, so these are the three events that happen in diastole that determine where the leaflets are prior to the onset of ventricular systole. Obviously ventricular systole is marked by the closure of the leaflets and then by isovolumic contraction. So now the closure of the leaflets, okay, the loudness of the sound produced by that would depend on what? So the loudness is intensity of sound. Okay, that is the total maximum amplitude of the waves that are produced squared. Okay, so that is directly related to the kinetic energy of the leaflets as they close. And the kinetic energy of the leaflets are obviously they have an angular momentum, so they're going back to their closed position. So the angular momentum of or the angular velocity of the leaflets will be more if the leaflets are closing from initial position that is further away from their closed position, and it will be less if they are closer to the closed position. Okay, therefore if the leaflets are very far away from their closed position at the initiation of systole, the sound produced or the wave amplitude produced will be very large, and therefore the intensity of sound will be very large, will be heard, and it will be heard as a louder S1 sound. Whereas if the leaflets are closer to their closed position, then there will be a soft S1 sound because the amplitude of the waves produced is subsequently lower. Now there are so what are the factors that determine this? So the angular velocity with which the leaflet closes would depend on one, the distance from where it is from where the leaflet closure initiates during early systole, during the initiation of systole. Second is it will depend on the pressure developed within the left ventricle, because it is the left ventricular pressure that is actually pushing the leaflet into its closed position. So that is obviously ventricular contractility. We've discussed this. Delta P by delta V, okay, is this curve that I've shown in this diagram, which is also the elastance curve, and that is directly related to ventricular contractility. So more the ventricular contractility and further the leaflets are from their closed neutral position, the louder the sound will be. Okay. The other factors are in a given patient, the mechanical properties of the leaflets may vary. So the leaflets may be very pliable or very soft, say in mitral valve prolapse or in mitral regurgitation. Alternatively, the leaflets may be of a prosthetic valve, a metallic valve. So they'll produce a very strong metallic sound, okay, very loud metallic sound. Then there is also the fact that the sound is actually being produced at the AV valve, and the AV valve there is overlying tissue between the AV valve and our steth, the diaphragm of our steth. So the acoustic impedance of the overlying tissue also reduces the intensity of the sound. So more the tissue and more the impedance, the softer the sound, and the reverse would be true also. Okay. So let's just systematize this a little bit more. So I'm going to shade out the parts of our diagram that correspond to systole. Okay, and except for the most, that is the initial portion of isovolumic contraction. So like I've just said, where the leaflet is at the end of diastole is the first factor that determines the loudness of S1. So that in turn depends on what? So that depends on, first thing it will depend on is the LV and diastolic volume, because the amount of blood in the LV determines how, in the second phase of diastole, how far the leaflet has been pushed towards its closed position. Okay, back towards the left atrium. Okay, now see, end diastolic LV volume is actually what? It is equal to how much was the flow rate between the left atrium to the left ventricle during diastole. Okay, and flow rate is just delta volume, that is change in volume over time. So times the time, that is the time of diastole, the total duration of diastole. Okay, so naturally this would mean what? This would mean that if the flow rate is high, okay, then LV and diastolic volume would increase. Alternatively, if the duration of diastole is increased, the LV and diastolic volume would increase, and the reverse would also be true. Okay, so the two factors that determine this are duration of diastole and diastolic flow rates during between the atrium and the ventricle. Okay, and lastly, see, even if a lot of blood is not going into the LV and the LV during diastole, sorry, this is volume, not pressure. Okay, what will happen is, if the internal diameter of the LV is small, okay, say there is some hypertrophy of the wall, only a little bit of blood has to go in before the pressure increases, and therefore the leaflets are pushed closer to their closed position. Okay, so the internal diameter of the LV also has an effect on the loudness of S1, or where the leaflets are at the initiation of systole. Okay, so I hope that is clear. So now we'll apply this to a clinical scenario and see how that works itself out. Okay, so if the only factor that we're considering is the displacement of the leaflets from the closed position at the initiation of left ventricular systole or contraction, okay, the first factor, or we'll divide it into two: soft S1 and loud S1. Okay, so we'll start with soft S1. So if there is soft S1, that means what? The leaflets were close to their closed position. They were nearer their closed position. So leaflet nearer closed position. Okay, so in that situation, that would mean either the LV end diastolic volume is increased, or the internal diameter of the left ventricle is decreased. Okay, so either the LV end diastolic volume is increased, or there is an increase in the LV internal diameter. Not an increase, a decrease in the LV internal diameter. Okay, so as we've discussed in the last slide, the increase in LV end diastolic volume could be because the diastolic period or the time of diastole is increased. So that would happen in what situation? That would happen with bradycardia. Okay, so as the heart rate slows down, it is actually diastole that prolongs more than systole. Okay, it would also happen with a block, a first degree heart block or a second degree heart block. Okay, now with higher grades of block, the diastole prolongs in various patterns. So actually you will get a variable softness of the S1 sound. Okay, but with first degree heart block, it is always soft. Okay, then the second thing that will determine it is a decrease in the flow rate. Okay, would be a increase in the flow rate. Okay, so left atrial to left ventricular flow rate obviously cannot increase unless left atrial pressure increases. Now if left atrial pressure increases, that is always due to back pressure from the left ventricle. So either way the gradient would not increase. Okay, so that cannot be the reason. So this happens when there is an alternate source of filling of the ventricle during diastole. Okay, so that is the case when you have got aortic regurgitation on the left side and pulmonary regurgitation on the right side. Okay, then lastly, LV internal diameter can be decreased if you have ventricular hypertrophy or you have a constrictive cardiomyopathy. Okay. Now, on the flip side, what if you have decreased LV and diastolic volume? Okay, so this would happen because either there is a decrease in the diastolic time, as would happen with an increase in heart rate, that is tachycardia, because diastole shortens out of proportion to systole when there is tachycardia. Or it would happen if there is a pre-excitation, that is the PR interval is shortened, the reverse of a first degree heart block. Okay, so one clinical syndrome that has this as a component is the Wolff-Parkinson-White syndrome, but other causes of shortened PR also would cause a loud SR. Okay. Now, the other thing that might happen is that there may be a decrease in the flow rate. Now, like I said, if the left atrial pressure decreases, the left atrial pressure as such is almost zero usually in a normal person, so it cannot decrease any further. Okay, so it is not a gradient related issue, so it has to be related to resistance. So resistance between the left atrium and the left ventricle is directly related to the diameter of the mitral valve or the tricuspid valve in the left and the right side. So therefore it is always due to mitral stenosis. Okay, and on the right side tricuspid stenosis. Now importantly, the mitral component is much louder than the tricuspid component. Okay, so therefore when I talk about loudness of S1, I'm usually talking about the left sided heart sounds. Okay, fine. The next parameter that we need to discuss is obviously the ventricular contractility, or with the force with which the ventricle contracts. Okay, so if that is decreased, you would have a soft S1. If it is increased, you would have a loud S1. Very clear, you know? So it would be decreased if there is ventricular systolic failure. Okay, and it would be increased if the patient is exercising or you given a drug like digoxin that causes increased contractility. Okay. Now the next factor is how much tissue or lies between the site of production of the sound and where you auscultate it, and the acoustic impedance of that tissue. Okay, that means how much of the sound is being scattered as the sound wave passes through that tissue. Okay, so see, fat, fluid and air. Okay, so the thing is that the acoustic impedance of normal soft tissue is not doesn't change that much. It does at when you pass ultrasound waves through it, and we'll discuss that during our discussion on ultrasound. However, for it is not obviously perceptible to the human ear, and we also don't know when the time of or onset at which the mechanical wave was initially produced. Okay, so what actually matters is actually the interface between the tissues. So if there is a major difference in the acoustic impedance of one tissue and the next tissue into which the sound has to go, then a lot of the sound actually gets reflected back. Okay, so this we'll see later. This is actually, if Z is the acoustic impedance of the second tissue into which it is going, it is Z2 minus the acoustic impedance of the initial tissue divided by the sum of the acoustic impedances of the two tissues. Okay, so that is how much sound will get reflected back. So if the gap is actually a lot, the difference is a lot, then a lot of sound gets reflected back and doesn't reach a state, so the sound appears very soft. So this happens when there is overlying fat, say in an obese patient. There is overlying fluid, there's pericardial effusion or a left-sided pleural effusion that is very large. Okay, there is air, that is any pneumothorax, pneumopericardium, emphysema, soft tissue, this thing, air accumulation. Okay, anything that causes hyperinflation of the chest. However, on the flip side, if there is less tissue in between the site of the mitral valve and the diaphragm, there will be a soft sound, there will be a loud sound. Okay, so that loud sound happens in people who are very slim. So slim individuals, you get a loud sound. Children also get a loud sound. The last parameter is obviously the mechanical properties of the valve. So if you have a very fibrotic calcified valve, okay, that cannot move, then actually that valve, those leaflets don't hit each other and they can't really be moved, even if you apply a lot of even if you try to push the valve towards the left atrium. Okay, so they produce a soft sound. and similarly, if the mitral annulus is enlarged, or the leaflets are somehow not closing properly, say in a mitral regurgitation or a dilated cardiomyopathy, then also the sound produces very soft, because the interaction between the mechanical interaction between the leaflets itself is not occurring. Okay. On the flip side, if you have a metallic prosthetic valve, then you get a very loud S1. Okay. Now, in case of mitral valve prolapse, usually the sound is soft, okay, but it can be a little loud also, because it depends on the exact way in which the leaflets hit each other. Okay. And after this, there is another component, non-ejection click, which we will come to in the next video. That is often that is often audible subsequently. Now, the second topic for today is splitting of the S2 sound. Okay. So when I think about splitting of the S2 sound, the first thing is I need to decide what is the definition of splitting. So it is a comparison of whether the sound, the S2 component of the sound at the pulmonary area is heard as two separate sounds or one single sound during inspiration versus expiration. So what happens is, if this is your right ventricle and this is your left ventricle, okay, this is your LV and this is your RV. During inspiration, as we've discussed in the previous talk, around 15 ml of blood comes into the right ventricle. Okay, and that increases the pressure within the right ventricle, and that pushes the interventricular septum towards the left side. Okay, towards the left ventricle. So essentially, what ends up happening is that there is increased RV end diastolic volume. Okay, and there is a slight decrease in the LV end diastolic volume. Okay, so normally they are essentially equal, because the cardiac output on both sides has to remain equal. Okay, so during normal expiration in a normal person, okay, the two ventricles end their contraction, that is their systolic contraction period, that is the ejection phase, almost simultaneously. Okay, there is a slight gap, but that gap is not perceptible to normal human ears. So it is always A2 P2, but A2 followed by P2, that is the aortic valve sound followed by the pulmonic valve sound, but this gap is very less, only around 30 milliseconds. Okay, so such a small gap human ears cannot differentiate. Okay. However, during inspiration, what ends up happening is the gap increases to around 50 to 60 milliseconds. Why does that increase? Because of what I've just described. Because the RV end diastolic volume has increased. So the RV has to push out more blood. Okay. And the LV end diastolic volume has decreased. So the LV has to push out less blood. Okay. So the LV finishes its work faster. So the A2 component becomes a little earlier. And the RV finishes its work later, so the P2 component becomes a little later, so the gap becomes a little bit more. Okay, so normally what you get is you get no splitting during the expiratory components of sounds of respiration, and you get a splitting during inspiration. Okay, so in order to auscultate this is actually a skill that has to be developed, and you have to do it in a very quiet room with a very ideally a good steth. Okay, so what you do is you put the diaphragm of the steth over the pulmonic area, the pulmonary area, and after that you concentrate on the inspiration of the patient, just the inspiration. Okay, ignore the expiratory parts and concentrate on the inspiration. Okay, you can do it alternatively also, and concentrate on the S2 sound. So if you concentrate only during inspiration, you'll notice that there is a slight difference between the two sounds. So it sounds they almost occur together, but if you very carefully listen, there will be a slight split. Okay, so that is what is called normal splitting. Now, if what happens is that splitting occurs during both inspiration and expiration, what that implies is that A2 is so much before P2. Okay, that is, the left ventricle is finishing its ejection so much earlier than the right ventricle that even during expiration they can be heard as two separate sounds. So you get a split during both inspiration and now during expiration also. Now on the other hand, there is something known as a paradoxical split. So in a paradoxical split, what happens is that there is no splitting during inspiration, there is splitting during expiration. So why would this happen? So See, splitting during this basically means that during inspiration, the two sounds are coming close together. Okay, so that means that during inspiration, the distance between, or the time between the two sounds is decreasing. That is, A2 and P2 are coming closer. So this can only happen if the P2 sound occurs before the A2 sound. Okay, so that means P2 has become earlier than A2. So this is the reason for a paradoxical split. Okay, now a single S2 is when both during inspiration and expiration you don't get a split. Okay, so these are the definitions. So coming to how do we conceptualize this? So in order to conceptualize this, the easiest way of thinking about it is like there is a race between the LV and the RV. Okay, there are two runners. One is the RV and the other is the LV. Okay, now LV is a muscular runner, very good at running. Okay, exercises regularly. The RV is a little bit lazy and doesn't do its job. Okay, the both of them have to run a race from a starting point till the end point. Okay, normally, like I said, during expiration the end point is the same. So the distance is actually the amount of blood that they need to eject. So that will be the LV end diastolic volume minus the LV end systolic volume. Okay, similarly here it will be the RV end diastolic volume minus the RV end systolic volume. That is basically the amount of stroke volume on both sides. Okay, so you can just say that it is the RV stroke volume, and here also you can say it is the LV stroke volume. Okay, stroke volume. Okay, fine. So basically, who gets there faster? So that depends on what? It depends first on the actual LV stroke volume. Okay, then it depends on the strength of the runners. Okay, so that would be the contractility. Okay, so how strong the runners are? As I've discussed, LV is usually stronger than the RV. Okay, it also depends on where the race ends. So we'll see the end point of the race. So the end point of the race actually is determined by equalization of pressures between the ventricle and the artery into which the blood is going. So this is the point at which the LV pressure becomes equal to the aortic pressure. Okay, and this is where the RV pressure becomes equal to the pulmonary artery pressure. Okay, so with this analogy in mind, okay, what could be causing changes? What are the parameters that could be causing changes in our patients, changes in the exact timing of the A2 versus P2 components? So these are the factors. Okay, first is, when does ventricular contraction start? Okay, so we presume that ventricular contraction on the right and the left side is initiated at the same time. But if one is occurring for earlier, then that will mean that it will end also earlier. Okay, so that is something that we need to take into account. The second thing is the total distance that the runners need to run. That is the total ventricular end diastolic volume, and therefore the amount of stroke volume that the ventricle has to push out. Okay, so the stroke volume is directly proportional to the ventricular end diastolic volume because of the Frank-Starling mechanism. Okay, then third is the ventricular contractility, how strong the runners themselves are. Okay, and the fourth thing is actually the pressure within the vessel after, or the valve through which the valve through which the ventricle has to push out the blood, and also the pressure in the artery after into which the blood is being pushed. Okay, so they work in opposite ways, and we'll see that. Okay, so what I've done here is, since I'm talking about the systolic parts of the cardiac cycle, I have highlighted the end of diastole, the isovolumic contraction, and then the systolic parts of this thing. Okay, so let's first talk about a wide split S2. So wide split S2 would mean that during inspiration and expiration there is split. Okay, That is clear. That is clear from the previous thing. So that would mean that A2 is coming much earlier than P2. The gap between A2 and P2 is very large. So this can happen if you have either or actually an early A2 or a late P2. Okay. So why would A2 occur early? So first thing would be the A2 is the closure of the the aortic valve. So that means LV contraction could start earlier. So that would happen if there is some for some reason the depolarization wavefront reaches the left ventricle earlier than the right ventricle. So this will happen if there is an accessory pathway inserting into the left ventricle. One, this could happen if there is a arrhythmia that is originating in the left ventricle. Two, okay, it could happen if you are pacing the left ventricle and not the right ventricle. Okay, so these are the three causes of a early initiation of A2. Okay, the second reason why A2 might occur early is because you have asked the left ventricle to do less work, that is push out less blood. Okay, that happens when you have decreased amounts of blood at the end of diastole at this point. Okay, so why would that happen? That obviously, like we've just discussed with S1, the total amount of end diastolic left ventricular volume, it depends on the duration of the diastole and it depends on the flow rate. So the flow rate could be low. That happens with mitral stenosis. Okay, or you may have the flow rate could be low, or what could happen is that the diastolic duration is shorter. So we've already actually covered that under the LV accessory pathway part. So that is the second cause. Okay, the third thing is that the volume of blood is normal only, but the amount of space available within the ventricle for that blood is less. So the pressures rise fast. As a result, the end diastolic volume cannot reach that volume. So the LA-LV pressures equalize earlier. Okay, so that happens with any type of constrictive or restrictive pathology. So that happens with LV hypertrophy and it happens with restrictive cardiomyopathy involving the LV. Okay, then the other thing is, see, we are asking the LV to run the same distance, that is eject the same amount of blood, but we have given the LV some kind of stimulant. Okay, so we either given the LV a digoxin, or we have attached a device on the outside of the LV that causes LV contraction to improve. So that is what you call LVAD, or an LV assistance device. Okay, then the last thing that can happen is that the LV has to push blood out, but the afterload is decreased. So it doesn't have to push it through the aortic opening. It is pushing it through a low resistance opening into a chamber with low pressure. So that happens when either the LV has to push the blood into the through the mitral valve into the left atrium because there is some kind of mitral regurgitation, or if there is a ventricular septal defect. And as of now, the right ventricular pressures have not increased because of the PH that eventually usually develops, but as of now has not developed. So VSD before the development of pulmonary arterial hypertension. Okay, so these are the causes of an early A2. Now, when do you get a delay in P2? So similarly, it could be because the starting of right ventricular contraction itself is delayed. So that will happen when there is a block which delays the conduction of the depolarization wavefront to the right ventricle. So that would be a right bundle branch block. Okay. The other thing is you've given a lot of work to the right ventricle to do. So there is a lot of right ventricular end diastolic volume. So that would be either because there is increased flow into the right ventricle during diastole. Okay, so why would that happen? That flow could happen because there is a left to right shunt. That is, there is either an ASD or there is a anomalous pulmonary vein that is draining into the right atrium. Alternatively, you could have blood coming back from the pulmonary artery into the left ventricle, into the right ventricle during diastole. So that would be a pulmonary regurgitation. Okay. Now, next thing that can happen is you've given the right ventricle the same amount of work to do, but the right ventricle is just not that strong. Okay, so that is what happens when you have RV failure or an RV myocardial infarction. Okay, so the contractility, there is systolic failure. Okay, and lastly, what happens is, and this is very interesting, when the afterload on the RV is increased. Okay, now see, there are two ways in which the afterload on the RV can be increased. The afterload is it depends on the diameter or the resistance through the pulmonary valve, and it also depends on the resistance in the pulmonary arterial system. Okay, but they have opposite effects. Okay, so when you have pulmonary stenosis, the right ventricle has to contract for a prolonged period in order to eject the same amount of blood. Okay, so therefore P2 occurs later. However, when you have pulmonary artery hypertension, okay, see, P2 happens when the pulmonary artery pressure starts to exceed the right ventricular pressure. Okay, so if you think about it, if the right pulmonary artery pressure is higher, it would start to exceed the right ventricular pressure early. Okay, so an increase in the pulmonary artery pressure actually causes the P2 to become earlier, not later. Okay, so it is only increase afterload in the context of a pulmonary stenosis, not PAH. Okay, so as you can see, without PAH, everywhere I have mentioned without PAH. Okay, so the next type of splitting that we can get is a paradoxical split. Okay, so paradoxical split basically means that there is P2 is earlier than A2. P2 is followed by A2. Okay, so this can happen either because the P2 is early, or it can happen because the A2 is late. Okay, now this is very similar to whatever we discussed previously. So why would P2 occur early? Because the initiation of right ventricular contraction is occurring early, say because of a accessory pathway inserting into the right ventricle. Okay, because of a arrhythmia that is originating within the right ventricle, because of pacing that is happening from the right ventricle. Okay, alternatively, we've given less work to the right ventricle to do. So the RV end diastolic volume has decreased, and that depends on the flow rate, and it depends on the diastolic time, and it depends on how much is the internal diameter of the RV. Okay, so the flow rate could be decreased in tricuspid stenosis. The space within the RV could be decreased in RV hypertrophy, and you could have a decrease in RV compliance in restrictive cardiomyopathy. Exactly the same as what we saw for the LV when we said there was early P2. Okay, now the last thing is when there is increased RV contractility. So as we discussed, in a normal person, LV contractility is always more than RV contractility. So if you give them digoxin, it preferentially causes increased contractility of the LV rather than the RV. Okay, so this such a condition doesn't exist. Okay, on the other hand, RV afterload can decrease. Again, just like we discussed for the LV, the RV can decompress into a low pressure chamber. So that would, in case of the RV, be the right atrium. Okay, so that would be a tricuspid regurgitation. Okay, alternatively, we could have a ventricular septal defect with the development of PH. Okay, so ventricular septal defect with the development of PH would result in right ventricular pressures being higher than the left ventricular pressure. So blood will go from right ventricle to the left ventricle during systole. Okay, that is our second cause. Okay, then you can have delayed A2. Now delayed A2 will happen either, very analogous to what we discussed earlier, either the initiation of left ventricular contraction is delayed, say because of a left bundle branch block. Okay, or the LV end diastolic volume is increased. Why does that happen? That happens because during diastole there is something that is filling up the left ventricle faster than it normally would. That could be a right to left shunt, as in an ASD with PH. Okay, or it could happen with aortic regurgitation because blood is coming back from the aorta into the left ventricle. Okay, then it could happen because we've given the same amount of work to the LV to do, but the contractility or the LV is just not been hitting the gym as much. So as a result, LV failure or an LV MI. Okay, alternatively, there could be an increase in the afterload. Okay, so here I specifically again mean stenosis of the outlet. So either aortic stenosis or hypertrophic obstructive cardiomyopathy, or even a supravalvular stenosis, but I do not mean systemic hypertension. Okay, so just like I discussed with PAH causes the pulmonic valve to close early. Okay, because the closure depends on the difference between the pulmonary artery pressure and the RV pressure. If the pulmonary artery pressure increases, the pulmonary artery pressure will exceed the decreasing RV pressure during the end of systole earlier. Okay, so that time actually is called the pulmonary hangout time, and so that pulmonary hangout time is decreased. The same analogous thing happens in the left side also. So if you have systemic hypertension, A2 is slightly earlier. Okay, not delayed. I hope that is clear. Next we come to what is called fixed splitting. So see, this splitting happens because there is a difference in the end diastolic volumes during inspiration between the right and the left ventricle. But what if the right and the left sides of the heart were connected to each other? So if that happens, then you end up getting a equalization of pressures on the two sides during inspiration. So some of the extra blood that is coming to the right side actually shunts from the right to the left side, and as a result you end up getting a fixed split. Okay, such a fixed split is called a wide fixed split. Okay, so this is because now why is it wide? It is wide because A2 is occurring a little bit earlier and P2 is occurring a little bit late. Okay, so why would that happen? See, basically you end up getting a wide fixed split when you have an atrial septal defect. Okay, so in an atrial septal defect, left sided pressures are higher. Okay, so blood, there is an additional source of blood going into the right ventricle. So during inspiration, your right ventricle as such was getting more 15 ml more blood. Now it has to deal with a little bit more, but say another 15 ml, so 30 ml, 40 ml of extra blood to push. So it gets delayed, and that blood is being shunted from the left atrium into the right atrium. So therefore it is decreasing the amount of blood that the LV has to push out. So as a result, A2 becomes earlier and P2 becomes late. And this is fixed. This regardless of whether it is expiration or inspiration, since the two chambers, the LA and the RA are in continuation with each other, the pressure is equalized. So there is no difference. A variant of this would be the anomalous entry of the pulmonary veins into the right atrium. Okay, so that would be a partial anomalous pulmonary venous return. Okay, to the right atrium. Okay, so that behaves like an ASD only. Okay, now on the other hand, what can happen is you can get a wide fixed split due to just a very early A2. That happens in a VSD without PH, or a very late P2. A very late P2 would happen in two particular situations in which there is very late P2, that is RBMI and pulmonary stenosis. Okay, so these are the causes, 5 causes of a wide fixed split. Okay, and this is a question that is routinely asked. So there are 5 causes, it's not just ASD without PH. Okay, now there is also another situation. The S1 can become split if there is a right bundle branch block. So because of that, you can have the left-sided S1 occurring much earlier than the right-sided S1. So that becomes split, and that will be a fixed split. It will happen regardless whether you are inspiring or expiring. Okay, so that would be another type of wide fixed split. So this is a bonus answer that you can give. Okay, now there is also what we call a narrow fixed split, and as we've already seen, pulmonary artery hypertension causes the P2 sound to become earlier because the pulmonary hangout time is decreased. The pulmonary arterial pressure is high, so the gap between the pulmonary arterial pressure and the right ventricular pressure, as the right ventricular pressure is decreasing during the end of systole, the gap becomes closes down faster, so the amount of time taken is lesser. Okay, so as a result, you end up getting a P2 that is a little bit earlier. Okay, so it overlaps with A2 and you get a fixed split, but a narrow fixed split. Okay, now coming to the S3 and S4 sounds. See, both S3 and S4 sounds are diastolic sounds. Okay, they correspond to what? So the S3 sounds corresponds to the early diastolic filling. So, and the S4 sound corresponds to atrial contraction causing increased blood flow into the left ventricle. So that is your S4 sound. Okay, so see, both sounds are caused by a pressure gradient that is less than 40 millimeters of mercury. So when that is a general rule, if the pressure gradient is less than 30 to 40 millimeters of mercury, the frequency of sound produced is typically low. So they are both low pitch sounds. Okay, now similarly, the S1 would also be a low pitch sound. Okay, in normal circumstances, unless there is a metallic well, whereas the S2 is a high pitch sound typically. Okay. Now S3 happens when there is increased flow rate during the early parts of diastole. Okay, so that happens when you have either during physiological conditions in pregnant ladies or in athletes or in children, or alternatively it happens when there is an alternate source of filling of the left ventricle. So that happens with aortic regurgitation, mitral regurgitation, uh, a left to right shunt such as a patent ductus arteriosus, AP window, truncus arteriosus, or generally any high cardiac output state. It also happens when you have a dilated cardiomyopathy, a systolic failure of the left or the right ventricle, because the ventricle dilates, so the annulus dilates, so that causes secondary mitral or tricuspid regurgitation. Okay, now that increases that basically the Frank-Starling mechanism fails because there is a decrease in the contractility curve, and as a result, the ejection fraction starts to fall. Okay, so as a result, there is a little bit more blood left in the ventricle at the end of ejection, and because of that, there is the pressure gap between the left atrium and the left ventricle, or the right atrium and the right ventricle is lesser. Therefore, the flow rates decrease. Okay. So importantly, the presence of an S3 has a positive predictive value of 22 for heart failure. Okay, and this is a very good predictor of mortality at 2.5 years. So you can actually prognosticate patients based on the presence or absence of S3. Okay, now coming to S4. So S4 is due to atrial contraction. Naturally, if S4 is due to atrial contraction, it will be absent if there is atrial fibrillation. Okay, because atrial contraction is not occurring. Okay, now the thing is, there are only 4 causes of this. So that is, there is impaired relaxation at the end of diastole. Okay, so this happens either with myocardial infarction, that is because even relaxation is a active energy dependent process. It happens with the hypertrophy of the respective ventricle. So it happens with hypertrophic cardiomyopathy. Then it happens with restrictive cardiomyopathy. Okay, so these are the only 4 causes of S4 sound. Now, importantly, it has been reported in some literature to occur in men after 40 years of age. Okay, this is very old literature, and I'm not very sure whether those patients were assessed, echocardiographically. So I would take this with a pinch of salt. Okay, but almost always, if there is an S4, that is a pathological S4. Okay. Okay. So that brings us neatly to the end of this discussion. In the next discussion, I'll be discussing added sound, and I'll be giving you some interesting situations in which your normal heart sounds behave a little bit differently. So thank you, and I'll see you in the next video.